Uh, we are going to have a very thought-provoking and stimulating session. It is about the speakers are going to discuss about research which they have implemented in their clinical practice. Our chairperson for this session is Dr. Krishnan. She is professor and head of the department, anesthesia care at Cancer Institute, Adyar. Years of
Yeah. So I see the previous slides. Okay. We're going to be having the next session on going on from the journal to the bedside. Now, it's going to be done by 3 speakers, one after the other. The first talk would be by Dr. Shobha Nair. She's professor and head in the Department of Pain and Palliative Medicine at Amrita Hospital in Kochi. She's over 20 years of palliative care experience. Her areas of interest are pain and non-malignant palliative care. She's also was a former member of the Specialty Board of MD Palliative Medicine of Medical Council of India. And she's also had teaching hospital experience in UK. She's going to be speaking on NeoFam. The next speaker would be Dr. Suresh Reddy. He's a professor from the University of Texas, MD Anderson, over 28 years of experience. His area of interest is pain management, non-medical use of opioids, and patient burnout and caregiver burnout. His major achievements are fellowship program director for over 20 years. He's a faculty in the education of William Randolph Hearst Foundation. The next speaker would be Dr. Gayatri Palat. Dr. Gayatri may not be able to join us. However, she's recorded her talk. She's a professor, Department of Pain and Palliative Medicine, MNJ Institute, Hyderabad. She's a consultant in Two Worlds Cancer Collaborative Canada, board trustee, International Children's Palliative Care Network, founder member of Pain and Palliative Care Society, has more than 15 years of palliative care experience. She's mainly has been focusing on pediatric palliative care and played a key role in establishing district-based palliative care program in Telangana. Over to Dr. Shobha Nair to start the first talk.
Good evening, everyone. I'm Dr. Shobha Nair, and I'm going to talk about NephPAM in this section from the journal to the bedside. I hope you're all having a great time in the conference so far. Right. So if you look at the background of analgesics, it is very important as palliative care physicians. And the common analgesics that we use takes in paracetamol. And as you know, there are a lot of side effects for all these analgesics, like nausea, vomiting, constipation, gastritis, hepatorenal toxicity, etc., etc. So the goal of a balanced analgesia or a multimodal analgesia would be optimal levels of analgesia, both at rest and during movement. This goes without saying. And this will reduce opioid-induced side effects in hospital stays and or an additive effect to the analgesia. If you look at the pharmacology of NephPAM, it's a non-opioid, non-NSAID, centrally acting compound, and it has a diphenhydramine ring. Orphenadrine is a muscle relaxant and reduces tremors in Parkinson's disease. Diphenhydramine, as we know, is an antihistamine. But NephPAM does not have the sedating effect of both these medications. Even if it has, it is very mild for some patients. Now, if you look at the story of NephPAM, it was developed in the 1960s, benzoxazosine compound, previously known as phenazosine, and it inhibits catecholamine reuptake. So initially in the 1970s, it was a muscle relaxant and used as an antidepressant, and later on it became an analgesic. In the 1990s, another property was found, and it was used for prophylaxis and treatment of shivering. In 2000, again, a decade later, it was used to treat severe hiccups. As we talked about earlier, it has a muscle relaxant property, so maybe that was one which helped in reducing hiccups. Now, if you look at the pharmacology, if we give it per oral, 60 milligrams, 29 to 67 nanograms per ml is achieved in 2 hours. Intramuscular, 20 milligrams peak concentration in 1.5 hours. It's about protein bound and extensive biotransformation it undergoes. Elimination half-life is 3 to 8 hours. IV 10 or 15 milligrams and IM 15 or 30 milligrams comparable to opioids. What about pharma? The drug does to the body. So it produces noxiously evoked expression in the early phase of nociceptive process. BCGRP, etc. to act on NMDA. mRNA. And this forms a compound with like germline and combines with so C4 pain relief and will produce pain relief. Anti-nociceptive effect, we have anti-neuropathic effect, blockage of norepinephrine, just like antidepressants. Of glutamate. Okay, let's look at so antidepressant action. Okay. Norepinephrine transporter. So nefapam. Inhibition of long-term potentiation mediated by NMDA, just like gabapentinoid anticonvulsants. You can see a group of so calcium influx is inhibited and nefapam. Of voltage-sensitive sodium channels like carbamazepine. Neurotransmitters, norepinephrine, or a lot of problem. Mood instability. So it is worthwhile keeping all these neurotransmitters, up to the optimum level that is required. So what are the undesirable side effects of nefapam? It can cause allergic reaction or anaphylactic reactions, nervousness, convulsions, confusion state, hallucination, and insomnia, lightheadedness, syncope, dizziness, paresthesia, tremor, drowsiness, headache, and coma. and blurred vision, palpitations, tachycardia, hypertension, nausea, vomiting, dry mouth, gastrointestinal disturbances, angioedema, sweating, urinary infection. So if you look at all these undesirable side effects, then we probably would hesitate to give nefopam, but I'm sure like you all know that most of the medications have these lists of undesirable side effects, and we administer to individual patients, look the drug profile in that individual patient and decide whether to continue the medicine or not. So what's the dosage and administration? Per oral, 30 milligrams 3 to 4 times daily, can be increased to 60 or 90 milligrams. IM 20 milligrams Q4H to Q6H, IV 10 to 20 milligrams low Q4H to Q6H, IV infusion 10 to 30 milligrams over 2 to 6 hour period, and maximum in 24 hours per oral 300 milligrams, and IM and IV 120 milligrams. Elderly and renal impairment, reduced dose. So convulsive disorders and intake of MAO inhibitors, this is contraindicated. So please bear in mind that if you have nephrotoxicity, we might prescribe nefopam. And when we prescribe opioids, the opioids will the threshold. Of course, we are prescribing in a reduced dose of opioids, but still they have a propensity to lower the seizure threshold. We are giving nefopam with that. That would be detrimental, or this can add on to the convulsive effect of nefopam, although it has got an anticonvulsant property. Very strange. Anyway, so what is the pharmacoeconomics? Injection 20 milligrams costs around 24 rupees, and oral 30 milligram tablet rupees 8. It is similar to tramadol and tapentadol. So what is the evidence we have for prescribing nefopam? We have talked about pharmacokinetics and pharmacodynamics, and we now conclude that it's got great antinociceptive, antineuropathic, anticonvulsant property. Looks like an ideal drug. So what's evidence for using this in clinical situation? So here's a paper published in 2016 with Girard and team, titled Nefopam Analgesia and its Role in Multimodal Analgesia, a review of preclinical and clinical studies, published in Clinical and Experimental Pharmacology and Physiology. So the preclinical studies in combination with opioids, if you look at the test, it's on mice and rat, which is expected, and nefopam regimen is kilogram or 5 milligrams per kilogram intraperitoneal subcutaneous per oral routes, 10 to 30 milligrams per kilogram, different doses, different routes, and multimodal regimen along with morphine, again in different routes and different doses. So effect, you can see that all of them produce enhancement of morphine antinociceptive effect. Now, preclinical studies in combination with anti-inflammatory drugs. So acetic acid-induced abdominal writhing and post-operative thermal hyperalgesia. Nefopam regimen dose range for subcutaneous and 10 milligram per kilogram subcutaneous, where the dose is given. Multimodal regimen, ketoprofen was given with a dose range of 30 to 100 milligrams per kilogram. And the effect that they said was it was an additive effect. Okay, none of them said synergistic, but additive effect, an enhancement of ketoprofen antinociceptive effect. Nefopam in the dose of 3 to 10 milligram per kilogram, paracetamol 300 milligram per kilogram subcutaneous. Enhancement of paracetamol antinociceptive effect was seen. So what about clinical studies in combination with opioid? We have randomized, prospective randomized double-blind, in the last one, again, prospective randomized double-blind. So what was the type of surgery? Hepatic resection, hip arthroplasty, total knee replacement, etc. And the nefopam regimen, 20 milligrams IV every 4 hours, 20 milligrams IV every 4 hours for 24 hours, an IV bolus, etc. So multimodal regimen, again, PCA morphine, all three groups of patients. And so what was the effect? So reduction of morphine in the first study, consumption at 24 hours by 50%, reduction of morphine consumption at 24 hours by at least 20% in the second study, and reduction of morphine consumption at 48 hours by 30%. So we can see that there's a range between 20 and 50% of morphine consumption when nefobam was used. So clinical studies in combination with NSAIDs. Again, this was prospective non-randomized. The first one with the hip arthroplasty and the other one being in cancer, head and neck. Continuous infusion of 20 milligrams followed by 120 milligrams for 48 hours was used in the first study, and 30 milligrams IM before surgery and every 8 hours in the second study. Multimodal regimen was used in both studies. The first one, paracetamol with ketoprofen, ketamine, and PCA morphine, droperidol. Second one, tenoxicam 20 milligram IM or ketoprofen 100 milligram IM, tramadol, and paracetamol. Now, what was the effect? Full study, there was no improvement in pain relief, but alleviated several side effects. Right. So maybe the use of other medications came down, but there was no improvement in pain relief. That was a hip arthroplasty, very painful condition. Second study, efficient multimodal post-operative analgesic. Okay. Again, a prospective randomized double-blind in tonsillectomy, continuous IV infusion, initial dose 20 milligrams, short perfusion in the multimodal area with paracetamol, initial dose 1000 milligrams. Median effective dose, isobolographic analysis showed synergy. Okay, so that's even better. It's more than additive effect. So synergistic effect is when two drugs are combined together. It shows more than the individual effect of the two drugs. That is, 1 + 1 is not equal to 2, it is more than 2. Now, just talking about one study that we did in our institution, which is Amrita at Kochi. In fact, one of our team members presenting this in the oral presentation, which is titled Indications and Outcomes of Nefobam Administration in Palliative Care Patients, an observational study. And we found that the pain score before and after 24 hours was significant. Pain score before and after 48 hours was significant. Score after for 24 and 48 hours was significant also. Now, significance of less than 0.0001, that is highly significant, right? And this was an interim analysis of 71 patients. And we adjuvant to opioids for optimal pain relief. And 40% of these patients had hepatic or nephrotoxicity or low counts. So we were forced to give nefobam for such patients. And the rest we used it as an adjuvant to opioids. So what is a summary? Nefobam displays a number of clinical characteristics that supports its use as a unique analgesic. As we said, it has an anti-nociceptive effect. It has an anti-neuropathic effect, in which there is an antidepressant effect and an anticonvulsant effect, all of which would be helpful in controlling pain. It has a better side effect profile when compared to ketoprofen and opioids. It decreases morphine consumption, and the efficacy and safety properties suggest a strong role in multimodal analgesia regimens. We've been using nefobam regularly since 2019, and we made available oral and injections in our institution in 2019, and every department is using it, especially surgical departments, during even recovery from surgery in the post-op area where patients are recovering. So it has received good scores as far as pain relief is concerned from all over different departments is what I mean. And it is our observation that some patients it can be used alone depending on the severity of pain, but majority of our patients it is used as a part of multimodal analgesia, and we have found that it is a very useful drug to have in our armory of analgesics. If there are any questions, I can take them. Thank you for your patient listening, and thank you IAPC and Dr. Anjum Khan Jodh for this opportunity.
Hello, my name is Suresh Reddy. I work at MD Anderson Cancer Center in Houston, Texas. And thank you for the opportunity. I'm going to share the research, actually not one paper, several papers on the topic of fatigue, cancer-related fatigue, what we call CRF. This is a very distressing symptom. That's why I chose it. And there are some good level 1 evidences for the interventions for fatigue. So I'm going to share with you the level 1 evidences and also the different other treatments, pharmacological treatments that have been shown to be beneficial. So before we go to that, I just want to go over the definition of fatigue. It is a persistent subjective sense of physical as well as emotional level, or a cognitive tiredness or complete exhaustion relating to any disease, but we are related and its treatment, and interferences with usual functioning. So that's a complete, I like this definition, but this incorporates all the components of fatigue. And this is from a paper. As you see, the prevalence of fatigue is high, and across different diseases, cancer is anywhere from 32 to 90%, and AIDS, heart disease, chronic obstructive pulmonary disease, and renal disease. So across all disease spectrums, fatigue is a very common symptom and very distressing too. What are some of the mechanisms for fatigue? One is inflammation. We are all aware in cancer. Cancer releases a lot of these interleukins and tumor necrosis factor alpha and other interleukins, different interleukins, and that causes cachexia and cause fatigue. And other mechanisms include some of the medications, opioids we are very familiar with, benzodiazepines and tricyclic antidepressants can cause fatigue. And cancer treatment themselves, as we all aware, like radiation, immunotherapy, chemotherapy, endocrine therapy, including other symptoms like anxiety, depression, pain, dyspnea, cachexia, can lead to that. And if you add comorbidities or endocrine issues like hypothyroidism or testosterone deficiency, vitamin D deficiency, infections and kidney disease, they all add to fatigue. The reason we need to know them is the treatment of fatigue is obviously you have to treat underlying cause like cachexia, autonomic failure, anemia, and we are familiar with blood transfusions, lightening up a person quickly. Infection, once you treat infection, the fatigue kind of subsides. Hypoxia, of course, hypogonadism, and it's well known fact that opioids cause hypogonadism, decreased testosterone, and supplementation of testosterone can improve fatigue. Of course, depression and other factors that to treat them. Before you go on to say that let's treat it symptomatically. Treatment includes the star indicates level 1 evidence that we have so far to treat fatigue, and in pharmacological corticosteroids undergoing a lot of research right now. There's the promise, and our colleague Dr. Yano did excellent work on this, and others are doing in the country and in the world that show that corticosteroids form level 1 evidence to treat fatigue on a temporary basis, have their own issues. Then psychostimulants, we are all used to prescribing this for fatigue, may not be useful in all situations, but we will talk in a minute about the evidence and what kind of scenarios this may help. Ginseng and all that, they've been disappointing. And then non-pharmacological fatigue, for example, physical activity, both aerobic or resistance exercises, and yoga. There's a level 1 evidence, by the way, to improve fatigue. And then psychosocially, cognitive behavioral therapy, CBT, has shown to have treatments that we do, like psychoeducation, supportive expressive therapy, massage, and all that. Acupuncture has level 1 evidence. Acupuncture, cognitive behavioral therapy, yoga, physical activity, these are all level 1 evidences, and possibly corticosteroids are approaching level 1. And the psychostimulants, most of the studies are open label. So we are talking about level 2 and level 3 evidence for this. But 1, steroids, 2, physical activity in yoga, and cognitive behavioral therapy and acupuncture. These are all level 1 evidence for treating fatigue. By the way, like we said, this is symptomatic treatment, like most of I've seen. So the evidence for physical activity is by 2 aerobic exercises. They noted improvement of fatigue, quality of life, strength, including triglyceride levels and body fat. There are different exercises for resistance exercises. They are the ones to help fatigue. And the physical therapist will have a program for patients to deal with this. Then in the Cochrane meta-analysis, there were 28 clinical trials, including 2,000 patients, showed physical activity improved fatigue, both during and after treatment for cancer. So it's pretty significant. Okay. And cognitive behavioral therapy studies, even though the size was small, the effect size was small, the 9 studies had positive findings, all these studies. Unfortunately, hypnosis and physical activity, depression. So that as a primary outcome, fatigue was most studies pointing towards improvement in fatigue. But cognitive behavioral therapy is long duration, and it involves a lot of sessions, not a quick fix. So we need to work with a psychologist to get benefit from cognitive behavioral therapy. Then we are aware of hemopoietic growth factors that we used to give initially, but now we don't. Erythropoietin and darbepoetin, they both improve fatigue in patients receiving chemotherapy, but because of the complication, thrombovascular events and tumor growth, we pretty much abandon these agents. Most studies are open label, okay, and the blood transfusion, we give mostly liquid tumors like leukemia. They do benefit temporarily, and some people get dependent on them, but evidence for that is the short-term benefit in fatigue. Then come to the pharmacological agents. It include established. It is well established that dexamethasone that our colleague used improves fatigue, no question, as a level 1 evidence. Then methylphenidate, what we call Ritalin, or any psychostimulants, improves fatigue, but not in all situations. And then other agents, have been disappointing in improving fatigue. We still use ginseng and melatonin and all that, but evidence is lacking for those. So psychostimulant specifically helps with the opioid-induced sedation. That's where we started, really. Opioid causes a lot of sedation. There's a good evidence for that, and a good place for using psychostimulant for opioid-induced sedation. It also helps with hyperactive delirium, Depression too, if somebody has depression, is shown to help, but lacking level 1 evidence. So first study was from Bruera in 2003. It's an open label study, used 3 to 4 doses a day as needed, methylphenidate, and in which he noted 30 out of 30 patients chose to continue methylphenidate. All patients took afternoon and evening doses. It improved appetite, insomnia, and anxiety also. So he noted that in addition to fatigue, it improved other symptoms. As you see, the baseline fatigue was 7.2 in the ESAS, and then came down to 3.1. It's significant. Okay. And then he did a patient control for cancer fatigue. It's a blind, randomized, placebo-controlled trial. Pretty interesting study. He started with 143 patients, and then after non-eligibility, it came to 112, and they're equally distributed between placebo and methylphenidate. And there are a few dropouts, but eventually valuable patients were equal, 53 and 52. And then if you go into demographics, median age is pretty common. Males is more in the group, but mostly solid tumors. And we use these different scales, facet fatigue and baseline ESAS fatigue. So they're all comparable. Excuse me. And you see the day, both, this is a methylphenidate group, this is a placebo group. They showed significant improvement in fatigue, both placebo and methylphenidate. That's when the methodology of the other studies came into question. So placebo is doing the same thing. And after day 8, on day 15 and day 36, with methylphenidate, continue to show improvement in fatigue. Side effects between methylphenidate group and placebo group, pretty similar if you look at it. We would thought placebo causes restlessness, insomnia, and anorexia. So side effects were not dissimilar between the two groups. So if you look at the methylphenidate meta-analysis, it's a very important slide. Most of the studies favor, except one, ORET study in 2009, most of the studies favor methylphenidate. But people use for different reasons, and that's why it's important how methylphenidate matches. Kind of fatigue, it really improves. So this shows that methylphenidate has a favorable outcome for using in fatigue, but in a selected group of patients. This is because there's a lot of research on methylphenidate, and it does favor fatigue. So in conclusion, I'd like to say a combination therapy, like we have seen, pharmacological and non-pharmacological, including cognitive behavioral therapy, physical exercise comes foremost when you want to combine therapy. So selection of patient is important, like we were mentioning. Fatigue and sedation from opioids will benefit from methylphenidate, no question about that. There's a good level 1 evidence. And fatigue from cancer will benefit from steroids, approaching level 1, and physical activity, approaching level 1. So in short, I would say fatigue, the research in fatigue over the last few decades has shown that not single agent or not single therapy is useful. What I mean to say is monotherapy is not useful. You have to combine different treatments, like most symptoms in palliative care. I'll conclude here, and I'll be happy to questions. Thank you for your attention.
A very good evening to all of you. Welcome to one of the second presentation which we intend to do in the session 6, from the journal to the bedside knowledge translation. Is the article which I chose, and it is about patients with chronic kidney conditions. This article is a review article actually, and with the title Recommendations for the Care of Patients Receiving Conservative Kidney Management, with a focus on management of CKD and symptoms. And this came in Clinical Journal of Society of Nephrology, 2019. Why I chose this article? From in Indian context, Indian population point of view, India hosts patients with chronic kidney diseases. It is estimated that 90% of them actually they remain undetected and may die without accessing any kind of care. Whatever data we have about chronic kidney conditions in Indian population, it's only on those remaining 10% who report to the hospital with various reasons. The prevalence figure for end-stage renal disease in India, if you look at it, the different studies shows different prevalences. This is because of the fact that it's not actually capturing the real population-based statistics, but still there's a wide range, 129 to 229 per million population. And one of the southern states suggests the prevalence as high as 870 per million population. In a study which came in 2018, out of 13,140 patients who were on dialysis, it showed that only 2% of them eventually had a kidney. 4% of patients discontinued dialysis and 17% died while still on dialysis. Now, these numbers really underscore the tremendous of renal supportive care in the country. And not to forget the remaining 90% who never actually ever reach the healthcare facilities. We also know that patients with chronic kidney disease, they experience high symptom burden. And sometimes they are similar or they are reported that sometimes greater than that of advanced cancer patients. And conservative kidney management is increasingly accepted as an appropriate treatment option to eGFR category 5 CKD, who are unlikely to benefit from dialysis and who choose not to go for dialysis, non-dialysis care option. And once they go for this option, the conservative kidney management, the entire focus of care then shifts to shared decision-making, holistic patient-centered care, where we on quality of life, active symptom management, and advanced care planning. Now, with this background, when you look at, when you want to help these patients coming to us for opting for conservative kidney management, I thought this article was very useful. This article on recommendations for the care of patients management with focus on management of CKD and symptoms. The set of recommendations they gave in this article is about managing the complications of CKD and common symptoms which we encounter when dealing with patients with CKD. And these recommendations very much, they were aligning with patients' values and preferences and aiming to optimize comfort and quality of life. So it's not just about describing how to manage complications or common symptoms. They also describe based on patients' preferences. Now, these recommendations were created by an expert group. They called it as Conservative Kidney Management Clinical Working Group, consisting of Kidney Supportive Care Research Group and Alberta Provincial Conservative Kidney Management Steering Committee. The interesting part of this, how they form this recommendation, is that because these patients are often older with multi-system morbidity, they involved stakeholders who were patients, families, and people from various disciplines who were actually involved with taking care of these patients, like nephrology, palliative care, primary care, geriatric medicines, and other allied disciplines like pharmacy, dietitians, nursing, medicine, and social work. This really made it a very multi-stakeholder meeting, giving recommendation about how to manage these patients. And patients' voices were really heard. These recommendations were also backed by evidence wherever they could get it. They also gave recommendation based on patients' clinical conditions, pictorial kind of depiction as to where to opt, what kind of recommendation depending upon whether it's stable, deteriorating, or it's end-of-life care, rapidly declining. I just highlighted how the recommendation looks like in this article. If you look at it, this is the summary of recommendation for managing metabolic complications of CKD, patients receiving conservative kidney management. Various problems, clinical problems they have described, like blood pressure, dyslipidemia, sodium restriction, anemia, acidosis, calcium. With CKD. What they say is that anemia, it can contribute to fatigue and breathlessness. The purpose of treating anemia is to reduce these symptoms as opposed to reducing cardiac mortality and morbidity. When patients start spending most of their time confined to bed or chair, or are nearing end of life, it is no longer appropriate to manage fatigue and breathlessness by and can be stopped. So this is the recommendation we gave, and they talk about then what to do. Interventions should include then the use of, if at all you're managing anemia, suppose if you're looking at patients' preference as to completely conservative approach, this is what they recommend. But if you're still thinking about managing anemia, they say use of erythropoiesis stimulating agents, iron supplements, anemia-related blood work every 3 months is appropriate, but should be on the basis of patient preference and symptoms. So this is very interesting because many times we are going to face these kind of symptoms in our practice issues, and then this is a good reference point. Also, I just wanted to give example how they have given guidelines around symptom management. If you see here, I really like this because it's a very quick reference point. How to manage restless leg syndrome, uremic pruritus, nausea and vomiting, breathlessness in patients with uremia, fatigue and sleep disturbance. I'm just giving one example, like how I've taken one fatigue and sleep disturbance. They're given a recommendation. First of all, this side, they've described why patients with chronic kidney disease, they develop fatigue and sleep disturbances, like deficiency, vitamin D, medication toxicity, sleep disorders. And why sleep disturbances, they also described like how different reasons that they develop sleep disturbances. So what to do when you see because fatigue is something most common we see in patients with CKD. So they tell us as to what to do when you develop fatigue. Exercise, which are very fatigue and sleep. And third line, mirtazapine, because we often sometimes we are confused as what pharmacological management would be all right for a patient with such chronic kidney conditions. So they gave this kind of guideline, the recommendation. So this is a very quick reference for us who are practicing palliative care and seeing patients with chronic kidney conditions. So it is a review article. It comes with its own limitations, especially even today, we don't have a lot of evidence actually around many of these clinical recommendations, many of clinical conditions. Based on mostly, wherever there are evidence, they have taken the evidence, but otherwise it's an expert group. So, but what the outcome, thing which has really helped us, we met sometime back in the year 2019, when we met, all the national important people who are interested in renal management, palliative care people who are interested in renal management and also leading nephrologists from academic institutions. We all met in Manipal and we brainstormed as to how to take it forward. And we came out with recommendations, our own recommendation. And a lot of recommendation were reflected based on the article which I described. And we brought out a journal supplement on various aspects of renal management. And one of the important reference point was this article. And specifically, if you look at my clinical practice, I really thought this was very useful for me and for my team because it just helps us to important starting point for patients who required palliative care and with the conservative kidney care, because it's not only described the various symptoms and it was based on, the recommendations were based on patients' values and preferences with the aim to optimize comfort and quality of life.
Speaker, journals with a lot of conviction and clarity. Continue the steroids.
Balakrishnan, for hosting us. Be long day. I won't keep you long. Want a quick energy booster in nausea? Dexamethasone can be continued for a couple of weeks, and then you have to taper off. But if the goal is quality of life, prognosis, in fact, you can continue dexamethasone till they pass away. So it's a risk versus benefit. You have to, for patients in palliative care, they receive steroids till they pass. So all that, so you have to consider immediate benefits versus long-term side effects of. So scenario. Okay.
Okay. Thank you for that. Now, the recent December 2021 management is not, it's a practice review. They do not speak in favor of methylphenidate at all. What is your comment on?
Yeah, I think that's true. That's why I didn't put level 1 evidence for it. Most of the studies are open label. And our study, like Dr. Bruera did from our institution, you have seen that placebo is as good as methylphenidate. So it's a limited scope, possibly best in patients who are on opioids or sedated and feeling fatigue. That's the best scenario where you can methylphenidate. Other than that, we use it because we are desperate. Other measures are not working. But I agree with that recommendation that methylphenidate is as good as placebo. But level 1 evidence is mostly for physical activity, acupuncture, yoga, and behavioral therapy. I think you have to combine these rather than just use one medication or one therapy. You have to combine.
Dr. Anjum wants to know what is your experience with mirtazapine?
For fatigue or other symptoms?
For fatigue?
We don't use mirtazapine for fatigue at all because it's sedating. We used to use it for anorexia stimulant, but evidence which came out saying that it's not useful for anorexia. So this is fallen off a little bit, mirtazapine. Sometimes we use it for insomnia these days, mirtazapine. Antipsychotic like, mirtazapine, olanzapine, and quetiapine, this is what we use for insomnia. But mirtazapine is you know, whether you use it for insomnia, anorexia, or depression, the consequences, the side effects versus benefit it offers. We generally now are using olanzapine because it is useful for insomnia, plus it is very useful for nausea.
Seems to be, at least in this article, that there's a lot of role for acknowledging and validating the patient's feeling, so that goes a long way in helping these patients.
I think that goes with any symptom. That goes with any symptom in palliative care, or anything. any time you interact with the patient, that should be your basic clinical practice, right? Acknowledging the symptom, validating and empathizing with them should be the basic clinical practice now. We have shown that in palliative care.
And you have rightly said that all the complementary therapies, non-pharmacological management have a lot of role to play.
There are a lot of role to play. You can't forget those, combine those. We have seen that with the pain management. We have seen with nausea. We've seen with dyspnea. We've seen with all, frankly. So that goes to show that. And I think there is a new research coming, and our group is doing that. In fact, the placebo, the research with placebo is coming slowly. Like, tell the patient that they are receiving placebo. It was a double-blind randomized, but now we are doing studies telling them that, hey, this is a placebo. It is a placebo. There's no drug in it, and they have shown that even doing that will help patient. That is probably because it triggers that dopamine in limbic system. And you may laugh at me because I always talk about limbic system. It triggers some of the areas in the cortex in a positive way so that the symptoms are better. So placebo itself, telling the patient that this is placebo itself results in benefit. So that's why I'm not surprised that placebo versus methylphenidate, they didn't see much difference there.
There's a lot of talk about placebo and nocebo now.
Yes, placebo too.
Yeah.
There is a research, yes. When you give a placebo, it can cause negative effects.
Yeah.
There is 30% positive effect, but it can equally cause negative too. Absolutely. There's a lot of research on that. Nocebo, placebo is very interesting.
Yeah.
It's mind over body kind of deal, and which I agree with. Mind is a very powerful thing we have, but we neglect to use it sometimes.
That's true. I think there are no further questions. Dr. Anjum, is that, shall we close? Does anybody have any more questions? Thank you so much, Dr. Suresh, for,
Thank you for hosting me. It was a pleasure.
Thank you.
Thank you. Great session. Thank you so much. Great session. Thank you, Dr. Reddy.
Thank you.
Kalpana, thank you, Akanksha.
Yeah. Thanks.
Thank
Thank
you.
you.
Yeah,
Thank you so much, everybody.
Thanks.
Very interesting.
Bye-bye.
Bye.
Have a good night. Bye.